Good morning, everybody. So thank you all for getting up early on a Saturday morning to join us. My name is Susan Thornton, and I'm the CEO of the Cutaneous Lymphoma Foundation. And what I always like to say is that's my job, but the reality is that I'm also a patient. And I've been living with Mycosis fungoides for the last 23 years, give or take. So this day is all for you. It's all about you. It's about getting your questions answered. It's about learning more about the disease, because I feel like the more you know, the more you can take control, the more you can understand how things are going and work with your clinicians to manage it so that you can actually live the rest of your life just like you would if you didn't have cutaneous lymphoma. So without further ado, I'm going to turn it over to Dr. Lauren Pinter-Brown, who is here joining us from UCLA in California. And we just have her for a brief time this morning, but Dr. Pinter-Brown has been involved in the area of cutaneous lymphoma for a long time. I'm not going to say how long, for a long time. And she's seen lots and lots of patients in all different iterations. And she's going to discuss the clinical side of cutaneous lymphoma, but we hope that it'll be a very interactive kind of presentation. So ask your questions along the way, as things come up, so that she can get them answered for you. And with that, I'm just going to turn it over to Dr. Pinter-Brown.
Okay, good morning. I'm going to give a very broad overview going from what a lymphoma is, how do you diagnose cutaneous lymphomas, how do you stage people that have cutaneous lymphomas, and kind of an overview of how we select treatments. And then subsequent to me, we're going to be talking about clinical trials. So for people that are new, what a lymphoma is it's a malignancy that comes from a lymphocyte. Lymphocytes are part of our white blood cells. They come in two main varieties, B like in boy and T like in Tom. Each one causes many different kinds of lymphomas. There's over 70 different kinds of lymphomas in the world, and more get described. And so one cell gets crazy, and it basically makes copies of itself over and over and over again for no particular good purpose, and that's expansion of a clone. And that's what a lymphoma is. It's a clone of a lymphocyte. And lymphocytes, when they're doing their normal duties, are part of our immune system. B lymphocytes and T lymphocytes have complementary roles in our immune system. So these are actually blood cells, and they have access to our bodies. And so while most lymphomas in this country are B-cell lymphomas, and they're found in lymph nodes because that's where B cells live, T-cell lymphomas are found in other parts of the body, and probably the most frequent area is skin, because there's a whole group of T-cell lymphomas whose job it is to circulate through people's skin and report back into the lymph nodes if there's a problem that the immune system needs to address. So skin involvement with T-cell lymphomas is very, very common. So under the big umbrella of non-Hodgkin's lymphomas, you have all of these 70-plus lymphomas of B and T lymphocytes. So we're going to focus on T lymphocytes of skin. And skin lymphomas, why is there a specific foundation, as an example, for skin lymphomas? They're really different in a lot of ways. One way I already alluded to. So in this country, B-cell lymphomas are 80% of all the lymphomas, and they're in lymph nodes. Here, if you look at skin lymphomas, most of them are T-cell lymphomas. So it's kind of the reverse of what we're used to thinking about when we think about lymphoma. The other thing is that the behavior and the treatment for skin lymphomas are really different from maybe even the same looking lymphoma in a lymph node. And for that reason, skin lymphomas have their own classification and their own staging system. So if you read about the staging system for other lymphomas, 1, 2, 3, 4, and it's based on how many lymph nodes you have, it has no relevance to skin lymphomas whatsoever. The other thing that's really, really different, and this is kind of a concept that's hard even for some doctors to understand, is that in skin lymphomas, the pathologist doesn't have the final say. So it's not like breast cancer where they say, oh, this person has breast cancer, and the oncologist doesn't weigh in. Okay, fine, they have breast cancer. In skin lymphomas, the pathologist has to know something about what the person looks like to render an appropriate diagnosis. They cannot read it in a vacuum. So it ends up being a dialogue, or should be a dialogue, between a pathologist and a clinician about the pathologist saying, this is what I see under the microscope, and the clinician saying, this is what I see in the clinic, in the patient, and how do we come up with a diagnosis that makes sense, what I see and what you see under the microscope. And that's really different from other kinds of cancers. And as part of that, many people that have skin lymphomas have a team. So the team is composed of the pathologist and the clinician, and sometimes it can be a dermatologist or an oncologist. I know that there's always a big debate about who should take care of people, but really it should just be somebody that knows about this. And sometimes there's a radiation therapist involved. So just so you can kind of understand what pathologists do and what clinicians are looking at, this is a cartoon of the skin showing the structures in the skin and kind of what the pathologist is going to look at when they look at a skin biopsy. So, oh, well, I can't move away. Okay, so that brown structure you see, that's a hair. And you can see that the hair goes deep into the skin. So the skin has 3 layers: the epidermis, which is the very most superficial layer, the dermis, which is where things like skin reside, and finally underneath that, fat. So Mycosis fungoides, as an example, is somewhat unique amongst all the cutaneous lymphomas because it likes to live in the epidermis, whereas other skin lymphomas like to live further down in general. And because of that, they don't look the same to the eye. So Mycosis fungoides is something that's usually pretty superficial on the skin. It may have scaling on top, where some of the other lymphomas have more depth to them and are more like a nodule, like a dome-shaped kind of creation. So this is what an actual skin biopsy looks like. And again, you can see the epidermis is kind of deeply pink or magenta, and then you have the dermis, which is paler in color. I'll show you some abnormal slides in a little bit. And then, so the pathologist looks at those slides, and then they have tools they can utilize. And one of the big tools that hematopathologists utilize is monoclonal antibodies. Monoclonal means one clone, just like the cancer itself. But in this case, these antibodies are things that are usually created in a laboratory, and they're created for the purpose of diagnosis, for using them on slides. I'll show you an example, or for treatment, and I'll show you an example of that. So here's an example of all the monoclonal antibodies have a cluster designation. They have a CD and then a number to identify them. This is CD20. CD20 is positive in B cells. You can see all of these stains stain things brown. So all the brown that you see kind of rimming each cell here, that's showing that the cell has CD20 on it and showing that it's a B cell. So that's how the pathologist starts to figure out kind of what lymphoma that they're dealing with. They have a whole hundreds of these things that they can take off a shelf and just kind of figure out which monoclonal antibodies will help them identify what lymphoma it is. So talking about cutaneous B-cell lymphomas, mostly they're very, very slow growing. There's only really one aggressive type. And as I said, they're in the minority, so I'm going to talk about them a little bit and spend more time on T-cell lymphomas. Cutaneous B-cell lymphomas, they live in the dermis, so they look like raised areas. They don't look like Mycosis fungoides, and they grow really, really slowly. And their habit is that they like to return to the skin. Very few of them actually go in internally and go into lymph nodes. They just, for some reason, these cells, which usually don't live in the skin, they just like to be there. And so they like to return there, but even though they return, they don't really cause much harm to the patient, and the patients do very well. And so there's lots of ways you could treat that. One would be if there's just one lesion, just to radiate it. Another would be, I suppose, you could cut it out. You could inject it with steroids. Steroids to us, like prednisone, is like chemotherapy. It kills lymphocytes. So we will often use steroids as part of lymphoma treatments. And finally, monoclonal antibodies. So this is a good example of how an antibody can be used in treatment. So the very first monoclonal antibody for the use in cancer is rituximab. It revolutionized the treatment of B-cell lymphomas. And it's an antibody that's part mouse and part human, and it attacks the CD20. So when you put it in intravenously, it goes to the cells with CD20. Some of them it kills outright, But what it really does is rev up the immune system so the immune system kills those cells. And all these antibodies, they're pretty benign. I mean, you have to sit in a chair for a few hours to get it, but they don't cause hair loss, they don't cause nausea, they don't make the counts drop like chemotherapy. And so they represent a very important way of treating people. On the T-cell side, we don't yet have a good antibody, and that's part of what's going on in clinical trials, is to try and find the rituximab for T-cell lymphomas. So I'm going to spend the remainder of time talking about cutaneous T-cell lymphomas, and I'll skip over the CD30 parts unless somebody realizes that they want to hear about it. So the term cutaneous T-cell lymphoma is actually sort of an archaic term. It was developed in 1979 when monoclonal antibodies first became known, and people realized that Mycosis fungoides was a T-cell lymphoma. Before that, they really didn't know. They had no way of knowing really what the origin of it was. And at that time, Mycosis fungoides and Sézary syndrome were the only kinds of T-cell lymphomas of the skin that people knew about. So they used the word cutaneous T-cell lymphoma to talk about those two entities. But as we go on in time, what happens in the world of lymphoma is that every new technique lets people know that there's different kinds of lymphomas. And so now there's a bunch of cutaneous T-cell lymphomas, and they're all different. So this term doesn't have very much meaning anymore because it doesn't tell you which cutaneous T-cell lymphoma you're talking about. But still, Mycosis fungoides is the most common one, and Sézary syndrome, which still is thought to be a subtype of Mycosis fungoides, is a smaller component. So these are all the T-cell lymphomas that exist. I'm not going to talk about all of them. I'll just focus on Mycosis fungoides because that's the most common. So where does this weird term come from, mycosis fungoides? People always, they look up in the Merck manual and they see mycosis means fungus, and they come back to me and say, I don't have a cancer, I have a fungus, how dare you? Or fungoides sounds like fungus, but this is such an old term, and it unfortunately hasn't changed. In the 1800s, there was a French dermatologist who had a patient who had tumors, and he thought it looked like mushrooms. So he coined this term, and now we're kind of stuck with it for the time being. So that's where the term comes from. Mycosis fungoides has zero to do with fungus. It has nothing to do with it at all. And it represents the most common kind of cutaneous T-cell lymphoma. And as I mentioned, it's unique because it likes to be in the epidermis. And the medical word for that is epidermotropism. Just like a plant has tropism, or a desire to face the sun, these cells have a desire to be in the epidermis. And the reason they do that is that there's a cell there called a Langerhans cell that's feeding them. And you can see that when you look at something called Patry's microabscesses. That's something that a pathologist is looking for in the slide. I'm going to show you a picture in a second. Sézary syndrome was again described by Dr. Sézary. Sézary's not a medical word, and he put his name on it in 1938. And what he talked about were people that had cells in the blood. He called them monster cells. They were bigger than usual, and they had nuclei, the part that contains the DNA, that was very kind of convoluted, and they had a unique appearance. So these patients generally are all red, and their skin is scaly, and sometimes they have enlarged lymph nodes, and sometimes they have really not nice scaling or little, almost like paper cuts on their hands and on their feet. They have nail changes, they can get swollen feet, they can get eyelid changes, and it itches bad. Mycosis fungoides, you'd think that that's one thing, and you don't have to remember all this, but there's all different versions of it. It can look very differently in different people. It can look different pathologically. So I'm going to talk about a couple of subtypes that are important when we think about treatment. But we have to realize that not everybody's going to look the same. Even though we call this all mycosis fungoides, it doesn't always look the same on the person, nor pathologically. But here's a classic appearance on a skin biopsy. So usually in skin, you don't have those blue cells in the area in the upper dermis. And then if you look at the epidermis, this is what a Patry's microabscess is. So you see these blue cells, and they're living in like a little cave. And why they're doing that is that there's some other cells that are around that area that are feeding them. So they naturally want to go up there and stay in a little cluster to be fed. It's like the feeding trough. So a pathologist looks for this change because it's very characteristic of Mycosis fungoides. And that lets them know that maybe that's what the diagnosis is. And then they use their monoclonal antibodies. So as an example, CD3 is a marker of T cells to show that these cells that are in the epidermis, these are the same blue cells, and going up into the epidermis from the epidermis are T cells, in fact. That's how they figure it out, because they're marking with this brown stuff. So when somebody gets a diagnosis of any kind of malignancy, the next thing to do is staging. And as I said, the staging is very different for Mycosis fungoides. And some people wonder, what's the point of stages? So probably the most important reason is that it tells us what the appropriate treatment is. It also tells us in a vague sense what to expect. It tells us where do we need to look if we want to assess how the treatment's working. How do we know that it's working? Where should we look? And finally, when we do clinical trials, we have to compare apples to apples. We can't have one clinical trial that has early stage patients and compare it to the effects of a drug in later stage patients. So it's very, very important when we do clinical trials and decide what group of patients is actually going to be eligible or going to be studied in a particular trial. But what doesn't it tell us? So the stages in Mycosis fungoides, the first 3 stages really have to do with the skin's appearance. And some people think that naturally people have to go from stage 1 to 2 to 3. Somebody stage 1 goes, when am I going to get to stage 3? It doesn't work that way in Mycosis fungoides. The stages were arbitrary. They were based on the way people look, and they do tell us people's prognosis, which is the importance of stages, but one does not necessarily go from stage 1 to 2 or 1 to 4. It just doesn't work that way in this particular disease. The other thing that's really important is that the statistics that you might look at online about how people with different stages do mean absolutely nothing to the individual. First of all, they're old, but second of all, it's just a statistic. So it tells you kind of in general what might happen, but it doesn't tell you what would happen to you or your loved one because there's a big splay in outcomes. So that's another thing that's really important, not to focus too much on the number that you might see when somebody is talking about staging. So how do we stage Mycosis fungoides? It's very different. As I told you, these are cells that move. They're blood cells. So the cell that causes Mycosis fungoides has a pathway, kind of like a surveillance team. It goes from the blood into the skin. Then it drains out of the skin, goes through lymph nodes, and makes a cycle over and over and over again. And it has a way to communicate to its nodal counterpart, which is B-cell lymphomas, when there's a problem. So it's kind of like the foot soldier. It goes around, and then it stops off at the lymph nodes and communicates if there's an issue. So when we're looking to stage someone, we want to look at the tissues where we know that these cells are. So skin, lymph nodes, blood, and finally organs. So how do we do that? In the skin, sometimes people take pictures, or they document what the extent or distribution of skin lesions are. In nodes, we primarily examine, and if there's an abnormal node, we might biopsy it. In blood, there's blood tests you could do. So you can do a complete blood count, a CBC. You could do liver function tests. You can do a test called LDH, which is a tumor marker for pretty much all lymphomas. Sometimes we do viral serologies because sometimes something that's actually a virus kind of masquerades as Mycosis fungoides. And finally, you can do a test called flow cytometry, which is a way to look at cells that are flowing around in the blood, in a blood sample, and test them with different monoclonal antibodies to see what they are, to look for cells in the blood. And when we're looking at organs, primarily we're doing it by physical examination, but sometimes we might get PET CTs. So just because people always wonder what's the difference, I put a picture in. So what a PET scan does is somebody injects sugar into the person, and it's labeled. So it'll emit a particle that they can image. Every cell in our body uses sugar to divide. That's the gasoline of the body. So most cells are taking up sugar kind of at a slow rate. Some normal cells are taking up sugar at a faster rate because they need a lot of fuel. Your heart, hopefully our brains. Then there's things that are like lymphomas. They're there in the body, and they're taking up a lot of sugar too because they need the sugar to divide. And that's what they're looking at on PET scanning. They're looking to see, is there an area that's hot, that lights up, that isn't a normal structure. And then they use CT scanning, which is a very fancy way of doing an X-ray, but across somebody's body. So it's like you cut somebody's body, and then you turned it up on the end, and you looked at all the structures to see what the structure is it's taking up. So this is an example of a PET scan. It doesn't project that well. Somebody before and after treatment. So you see that after treatment, the things that are left is the heart. That's the big blob in the chest. And the blob lower down is their bladder as they're urinating out the sugar. And on the left side, all those other areas are lymph nodes. This is a B-cell lymphoma. So the staging system, as I said, has to do with how does the skin look. So this T staging has to do with if a person has patches or plaques, those are areas that you can either see just with your eye alone, or you can see them and barely feel them above the skin. Whether somebody has a tumor is very obvious. Everybody always wonders if they have tumors, but they're very obvious. They're like big raised things. Or if somebody's all red. The node part of the staging has to do with what it looks like if it's biopsied. And the blood part has to do with this flow cytometry. And then you also figure out what percentage of the skin is involved. This is a scale that's used for burns, like when somebody says the person has 70% burns on their body, this is how they figure out. They know each part of the body, how much of the whole body's surface area it is. So it turns out that your palm is 1%. So if you can cover up all your lesions with the palm, it's 1% surface involvement. So 10% is actually a lot, and that's the cutoff between 1A and 1B, is 10% body surface area. So this is kind of how you end up with a stage. 1A and B are people that have patches or plaques. 2B are people that have tumors. 3 are people that are red but don't have significant blood involvement. 4A1 is people that are red and have significant blood involvement. A2 is nodal involvement, and B is something that's an organ, like a liver or a lung or something like that. For people that are interested in B-cell lymphomas, those are the procedure for doing staging is the same or very close to the same as other B-cell lymphomas. We pay a lot of attention to somebody has symptoms. There's something called B symptoms, fever, very profuse night sweats, and very significant weight loss. We do a physical exam, we do blood counts, we do that same LDH, we do the same PET CTs, and then sometimes bone marrows, not so much for cutaneous lymphomas. And then there's a very complicated staging system that nobody uses, so I'm not going to say too much. There are a lot of treatment options in Mycosis fungoides, and you might wonder how a physician actually decides which one to use. So there are several considerations. First of all, the treatment is based on the stage. There are certain stages where certain treatments are inappropriate, and that's just the way it works. So we have to look at the stage. And obviously, we would look at how somebody's been treated before and if something has been effective or not effective. When people have very early stage Mycosis fungoides, stage 1A to 2A, primarily because the bulk of the cells are in the skin, we treat the skin. We know we're not going to get every single cell, and it will come back at some point, but you can get rid of a lot of it. So I'll talk a little bit about what kinds of things you can direct to the skin. People that have higher stage Mycosis fungoides generally get something that goes inside of them either by a pill or by injection so that it can treat everything at once. But when we look at people that have Mycosis fungoides, the vast majority have early stage disease. So we're talking a lot about skin-directed therapies. And these are old numbers, 1,500 new cases per year. We don't have a whole lot of new numbers. I'm sure it's not exactly correct, but that's kind of the number you see in the literature. So when we're talking about skin-directed therapies, again, we see topical steroids. A question that comes up a lot is that a kind of a cosmetic thing, or does that do anything? Steroids kill lymphocytes. It's a treatment. It makes the area go away because it's killing cells. They go away. For some people, that works. For a lot of people, it doesn't, or it works transiently, and then it comes right back again. There's also something called imiquinod that you can put on. It's a drug that's used for venereal warts. You'll think that's a little weird, but it makes the skin produce something called interferon, which we actually used to use more as a treatment, but injectable. And then finally, you can put chemotherapy into some kind of vehicle and put it on the skin. It doesn't get inside of the person, when it's nitrogen mustard at least. Doesn't make their hair fall out, doesn't make them nauseous, doesn't make their counts go down. We don't exactly know how it works, even though we've been doing it since the 70s. It probably works by stimulating the immune system, but that's something that can be done. We can also use retinoids, which are related to vitamin A. We can put those on the skin. And lastly, weirdly enough, light kills these cells. So we use light therapy. And there's different frequencies of light that can be used. There's narrowband UVB, and there's a compound sorolin that makes people very sensitive to light that people can take and then stand in a UVA box. We don't use radiation as much as we used to, but it's also a treatment option. So these are all options, and some of it, what is used, is based on a person's prior history. Is there a light box where they live? If there isn't, it's not a choice. Do they travel a lot? If somebody travels a lot, there's no sense in asking them to go to somebody's light box 3 times a week when they're going to miss it half the time. They're probably better off having nitrogen mustard, and they can put it in their suitcase and they can use it on their trip. So these are the kinds of considerations that you use, and also the extent of the skin disease. And then in systemic therapies, you see a whole long list here. Chemotherapy actually takes up a lot of space on this slide. I'll answer you in 1 second. And then, but we actually don't use it very much. In general, people use one treatment at a time. Often people end up on several treatments because they kind of keep getting layered. And it's based on convenience to the person, as I mentioned, what's available, both geographically or financially is also a consideration, what the side effect profile is. And there's certain treatments that work better in certain instances. That may guide the treatment. There are certain treatments that work faster than other treatments or work slower, and that might guide the treatment. And we want to, if at all possible, preserve the normal immune system. So across the top is stages, and then these are different kinds of ways that people are treated. So if you look at limited mycosis fungoides, and it's kind of color-coded, it's showing up today kind of yellow and orange. Yellow is topical treatments, orange is systemic treatments. So if you're looking at early stage mycosis fungoides and you're looking at topical chemotherapy versus phototherapy, we know that they're equivalent. Their response rate is 90%. What their response rate would be in other stages would be really low. It's just not appropriate. Then if we go over to the systemic side, the systemic agents, most of them that are listed here, have been studied in controlled clinical trials other than photopheresis. And they've always been studied in people that have had a lot of other treatments first, and across the board, the response rate's about 40%. Doesn't mean that if you used it sooner, the response rate wouldn't be higher, but if you look at the medical literature, it will always quote something around 40%, 37, 41. It's always kind of around the same area. So, in truth, when you're thinking about picking on either side, you're often looking very carefully at what does the patient need? Does this patient need a fast response right now because they're miserable or not? What kind of disease is there? What options are available for this patient? What other conditions do they have that might make you pick one or the other? So one thing is route. So some patient might say, there is no way I'm coming in for an intravenous therapy. Well, then that limits their options because we basically only have 3 choices that are pills. We have retinoids, like bexarotene is an example. We have methotrexate, which is an old-time chemotherapy, and we have vorinostat, which is an HDAC inhibitor. Other than that, the other systemic therapies are intravenous. So if somebody insists on getting a pill, then we got to work with those 3. Another way we look at it is rapidity of response. So in general, chemotherapy always works the fastest. Unfortunately, in mycosis fungoides, it doesn't usually last that long, and this is a chronic disease, so we don't use it very often. So short of chemotherapy, what has the fastest response? Probably HDAC inhibitors. And then things that are quote-unquote biologic or working with the immune system, like interferon as an example, or like bexarotene. They work very, very slowly. They work. It just, you have to be patient. You have to know that that's what they're going to do. The stage, I talked in general about early versus late, but there's also some divisions within that. So things that work with the immune system don't work so well if there's a lot of disease around. If somebody has node involvement or they have viscera, which is like liver involvement, things like bexarotene don't work very well. That's just they're not strong enough, they're not powerful enough. On the other hand, if someone has tumors, bexarotene seems to work very well. There's certain chemotherapies that work very well versus other kinds of biologics like photopheresis or interferon that don't work that well in that instance. The other example of how we might choose therapies is if somebody has some other condition. So let's say somebody has heart disease. There's certain drugs that could potentially hurt the heart, and you're going to stay away from them. I've listed them here. If somebody has diabetes, HDAC inhibitors makes their sugar go up. Might be something you don't want to do. Somebody has kidney disease. There's certain drugs that get out through the kidney. You can't use them. A history of depression, interferon can cause depression. So you kind of try and match up what the best thing is for the patient at that time. And then finally, availability. Many centers don't have a photopheresis machine. It's not a choice. Unfortunately, some people's insurance doesn't pay very well for oral drugs. If they're going to be mortgaging their house to pay for the treatment, probably isn't a good choice. So that's kind of how we look at it. So I'm going to show you some specific instances, and this is the only time I'm going to show pictures. This is a man that came in with hair loss. You can see as the top of his head. If you look at it very carefully, you can see in the middle of that space, there's little black dots. If you were to run your finger over it, it would be rough. And this is a man that has what's called follicular mycosis fungoides. Follicular mycosis fungoides, the cells, for some reason, like to go along the hair. So they're deeper into the skin where that hair was that I showed you. And they make the hair fall out. It's like having a plant in gravel. It doesn't want to grow in gravel. It's not going to thrive. The hair falls out. And similarly, if you think about it, if I shine a light on this and the cells that we're interested in killing are deep down in the skin, it's probably not going to work that great. So these kinds of patients may benefit from systemic therapy even though they have very early stage mycosis fungoides, as an example. And usually I use bexarotene, and the hair comes back and all of that. But it's a specific kind of mycosis fungoides where you can't just say, oh, it's early stage, I'm going to shine lights on it without thinking about it. And this is what it looks like pathologically. So the arrow shows you the cells going down along this structure. The structure that you see going diagonal in the slide is the hair. And then sometimes they make mucus or mucin, which makes the skin feel kind of boggy or wet. And you can see that as this blue, in this blue stain here. Another kind of mycosis fungoides that you see a lot in darker skinned people and particularly in younger people is called hypopigmented mycosis fungoides. You see how the skin is not all the same color? So there's some lighter areas and some darker areas. The lighter areas, believe it or not, are mycosis fungoides. And these patients do very, very well if they get light treatment. So another instance of where it's kind of a no-brainer. You see a patient like that, unless there's some really good reason why you can't use light, you're just going to send them for light therapy. And finally, all slow-growing lymphomas have the ability to change at some point and become faster-growing lymphomas composed of larger cells. We know that in the person because all of a sudden things change rapidly and they develop something larger like a tumor, and those patients are treated differently. If it's just one, we would radiate that and then treat in a systemic way to prevent any more from happening. But those kinds of patients generally get treated with systemic therapies. And lastly, just so I don't forget, there's two important other areas that people need to think about when they're treating patients that have mycosis fungoides. One is itching, because it's really a big problem for some people, and the other is infection, because the skin is our natural barrier between the outside world and the inside of us. So if the skin is involved, it's been scratched up a lot, it's open, people are prone to infections, and we have to be mindful of that. So in terms of itching, probably the most important thing is to make sure the skin is moist. It doesn't have to be something fancy. I have my patients using olive oil a lot. That's just what I use. Everybody makes a joke about it, but they like it. But if the skin is moist, the itching will be less. Sometimes we use steroids that are put on the skin. But then there's some drugs that people don't really think about using in the setting of itching, because they're used to thinking about itching like a bug bite. And that's caused by a drug called histamine, so they use antihistamines. But this kind of itching is more kind of a brain thing. It's more like a nerve problem. So we tend to use drugs that are sometimes used for nerve disorders, like gabapentin is an example. Doxepin is an old antidepressant that happens to work for itching. Aprepitant is a drug that's actually used for vomiting, for chemotherapy, but it works. Mirtazapine is another kind of antidepressant. Pramoxine is calamine. And camphor and menthol could be used like a drug that's over the counter called Sarna, has that in it. The concept is, and this is going to be so simplistic, but it's the truth, if the brain gets some other sensation other than the itching, it kind of drops the itching and it moves on to the other thing. So if you put ice on your skin, although I would not recommend that, or you put something cooling like eucalyptus, the brain starts thinking about the cooling thing and it drops the itching. It's like a distraction. Same reason why itching is always worse at night, because there's not so much distraction. Your brain just hones in on it. Same thing with pain. And finally, in the supportive care realm, we want to maintain the skin barrier as much as possible, and we want to avoid people having ports or lines, because they will generally get infected. Some people that are all red, erythroderma, have a staph infection on their skin, and they actually get a lot better when they get antibiotics. That's another kind of tip. And short of that, I'm going to stop, because someone else is going to talk about clinical trials, and we have a little bit of time if there's other questions. I'm going to start in the front and work my way back. All right, I'll give you an example. I'll repeat the question. Thank you. So the question is, what did I mean by when I talk to a pathologist and I explain to them how the patient looks? I'll tell you about somebody I just saw 2 days ago. So I saw somebody, and he's a young man, and what he has is little tiny skin lesions that are under the size of a quarter, and they come and they go. They come and they go. That's what they do. He got a biopsy, and the biopsy called it mycosis fungoides. But mycosis fungoides doesn't really look like that, little things that are the size of a quarter that come and go. So I had to call up the pathologist and say, you know what you're saying on the paper doesn't fit what I see in the clinic. And what I see in the clinic happens to look like lymphomatoid papulosis. Would you be okay with me calling it lymphomatoid papulosis? If I tell you that's what I think the patient has, and you go back and look at the slide, is there anything in that slide that doesn't fit? And they go, yeah, okay, fine. That's what he has. So the visual, and the behavior. So here, the visual is important, but the behavior is really important too. So when I ask them, how long have you had these? Well, they come and they go. I get one, then, after 2 months, that one goes away and some other one takes its place. And so the behavior, when you're talking to somebody about what does this do, how has this been for you, is very important in terms of figuring out what diagnosis is. So that necessarily means the clinician has to know what these things look like. Yeah. I'm still going to work my way around. So I'll go here, then I'll go here, and then I'll go in the back. I could be like a roving... I'll leave this on for the second. People that have one lymphoma have a higher risk of having other lymphomas. That's true on the B-cell side, and it's true on the T-cell side. So if you look epidemiologically at people with mycosis fungoides, they have a slightly higher risk of other lymphomas, and that could include a B-cell lymphoma. So there are people that have more than one kind of lymphoma in the same person. It's not a coincidence. You have more? Yeah. Okay, now you're going to have more with a microphone so everybody can hear you.
Okay, this is better, okay? Lymph nodes, are they ever affected by T-cell lymphomas? I've had a couple of times when I've had colds and things, and you could tell your lymph nodes have been affected.
Right. So what lymph nodes, the question is, can lymph nodes be affected by T-cell lymphoma? The answer is yes, but lymph nodes, what their job is, so they're all over our bodies in places that we can feel and places we can't feel, and they're connected. It's like a very, very, very complicated freeway system. And what their job is normally is to watch over a particular area of the body. So as an example, the ones in your armpit, because you pointed to your armpit, they're responsible for your arm. So let's say you get a cut on your hand and it gets a little infected. The message goes up to your lymph nodes in your armpit, we got a problem. The cells that know how to fight bacteria that might be in that cut start to expand, start to multiply, and as they do so, the lymph node enlarges and it usually becomes tender. And they go and they fight that thing. And then when the thing goes away, they die, and the lymph node shrinks back down. So when you get an infection, like let's say you get a cold, the common lymph nodes that would be responsible for your nose and your mouth would be these. So they may swell up, they may get tender, and then when the cold's over, they go back down. Lymphoma lymph nodes aren't usually tender and don't usually go back down, although that's not 100% true, but in general. So the answer is yes, they can be involved, but often when somebody has a skin disorder, the lymph nodes are enlarged because they're just doing what they're supposed to do. They see there's a problem in the skin, and they enlarge, and they're sometimes tender. And when the skin gets better, they go back down. You're
Okay,
good?
thank you, yes.
Okay, now we were going over here, and then we're going in the back.
I have a two-part question. I'd like an update on what's new in follicular tropic, and I do appreciate the slides that you just were able to show us. The second part question is, when you have consistent malignant clones in the blood that are the same as the malignant clones located in the skin, is that significant?
Okay, so I'll start with the second question first. So when we do these flow cytometric tests, sometimes you find that somebody has a clone in their blood. And the way that we tell if it's significant is exactly what you said, by comparing it to the clone in the skin and seeing if it's identical. Sometimes people just have clones of cells in their bodies, in their blood. It happens on the B cell side too. And we don't know what the significance of it is. They just walk around with it. Maybe it means nothing. Most of the time, probably means nothing. So you're exactly right. That's what we look at, is if somebody has a diagnosis in their skin and they have a particular clone that's been identified, then we look to see if that clone in the blood is the same exact cell, to know how much weight we should put on it. And then in terms of what's new with follicular trophic MF, I think what's new is that when I talk to my colleagues, we are all seeing quite a lot of it. I don't know if that's something that's different in Mycosis fungoides or if the pathologists are getting more savvy, although I don't really think it's necessarily a pathologic issue. And I guess what's new is old. I've been treating patients with follicular trophic mycosis fungoides for a long time with systemic therapies. And my own personal feeling is that when you look in the literature and you see that they don't do as well, I think it's because people treat them the same as all the other kinds of mycosis fungoides. Just like in the lymphoma world, we have to kind of tailor our treatments to the person. And I think to expect something that you shine on somebody's skin to get down along their hair is stupid. It's not going to work. My patients do great. So I don't see the same poorer prognosis that's in the literature, and my guess would be that it's because we've been treating kind of like a one-size-fits-all. You have stage one, you get light, without thinking about that maybe there's some differences within that group of people. We're going in the... Yeah. Oh, you did it? Okay. Other questions? Over there.
When you mentioned the lymph nodes swelling up, I've had experience with narrowband UVB of sometimes my underarm lymph nodes swelling up, and then it goes away in a day or two. So that is kind of common and not to be concerned about?
Yeah, because maybe your skin's getting a little burned, and so it's reacting. And that's what they're supposed to do. That's their job. You sure? Yeah.
Okay, one last. I think you've been very clear on it, but is there any relationship between Sézary cells and just regular MF? And how can you tell if the Sézary cells are there? When do you hit the panic button?
Okay. The question is, are Sézary cells really different from MF, and how do you know that they're there? These are really good questions, I have to say, because they're actually very controversial issues. So there's somebody at the Dana-Farber, who you're going to see a representative from the Dana-Farber, who has studies to show that the cells that create Sézaries are not the same as cells in Mycosis fungoides, and I personally believe that data. I think someday there'll be two separate disorders. Having said that, that isn't accepted right now, and so they're all, Sézaries is kind of under the umbrella of Mycosis fungoides. But it's very different because people that have Sézaries generally show up to the doctor all red. It's not that they weren't paying attention, that it used to be little patches and plaques and they just kind of let it go. That's the way their skin looks. And they don't look the same as other Mycosis fungoides patients. So my personal view is it probably is a different, maybe variation on the same theme. How can you tell if somebody has Sézary syndrome? Sézary syndrome has a definition. You have to have so many of these abnormal cells in the blood, has to reach 1,000, and you tell that by doing this test flow cytometry. So you get a sample of somebody's blood that's liquid, and they run it through a machine where the machine is labeling the cells with these monoclonal antibodies and saying how, then the cells go out of the machine, and the machine counts how many of the cells have each antibody, what percentage of the cells. And Sézary's cells have a particular pattern to them, and they figure out, are there too many cells that have this particular pattern that isn't normal? And if you really want to take it a step further, you can do something called T-cell gene rearrangement and prove that it's a clone, or not really prove, but get more evidence that it's a clone. And sometimes, that isn't a test that's done just in the community sometimes. Or if flow cytometry is done and sent to a reference laboratory like Quest or LabCorp, they're so focused on B-cell lymphomas that they don't focus so much on the T-cell part of it. You have to tell people specifically, I'm looking for a T-cell lymphoma here. Don't give me 20 B-cell markers and 2 T-cell markers and tell me everything's okay. So that's kind of how you tell.